الآن نأخذ موضوع البروتينيوريا. الجلوميرولار filtrate normally contains about 30 ملغ per liter protein. This corresponds to a total filtered load of about 5 gram per 24 hour. إذن الجلوميرولار filtrate normally يحتوي على حوالي 30 ملغ per liter protein, where this corresponds to a total filtered load of about 5 gram per 24 hour. Since less than 200 milligram of a protein is normally excreted in the urine each day, واللي half of which is tam horsefall mucoprotein. هذا الميوكوبروتين secreted by tubular cells. Tubular reabsorption and catabolism are very efficient in health. Proteinuria is described as glomerular proteinuria إذا glomerulus becomes abnormally leaky, or a tubular proteinuria when the tubular reabsorption of a protein becomes defective. وأكو نوع اسمه Overflow proteinuria. هذا يحدث في حالات إذا أكو abnormally large amounts of some plasma proteins, وهذني may lead to an overflow proteinuria. Protein may also enter the urinary tract distal to the kidneys. Example في حالات الالتهابات due to inflammation leading to post-renal proteinuria. إذن أكو نوع آخر من البروتينيوريا هو البوست رينال بروتينيوريا. في هذه الحالة البروتين ربما أيضا يدخل إلى urinary tract distal to the kidneys، وقلنا example عليه due to inflammation. If post-renal proteinuria is suspected, urine microscopy including cytology and culture should be carried out. Electrophoresis of a concentrated urine specimen may help to distinguish these forms of proteinuria. إذن electrophoresis للconcentrated urine specimen ربما تساعد لتفريق these forms of proteinuria. In tubular proteinuria إذا كانت tubular proteinuria, the proteins are mainly of low molecular weight, having been filtered through the glomerulus but not reabsorbed. أما في حالة in glomerular proteinuria, for larger proteins that have filtered through the defective glomerular are also present. إذن في tubular proteinuria, the proteins are low molecular weight بشكل رئيسي. إذن low molecular weight بيهن اتفلترت بالجلوميرولس ولكن ما صار بها إعادة امتصاص بالتيوبيولز but not reabsorbed. أما في حالة الجلوميرولار proteinuria فالlarger proteins اللي تتفلتر من خلال defective glomeruli are also present، أيضا تكون موجودة. Diagnostic testing of urine for protein should be part of the full clinical examination of every patient. وهذه التست detect الألبومين at concentration greater than 200 mg per liter، ولكن are less sensitive to other proteins, and in particular fail to detect the Benz-Jones proteins that may be excreted في حالة multiple myeloma. If the presence of proteinuria is confirmed, إذا وجود البروتينيوريا is confirmed, it should be quantified as protein to creatinine ratio, or in a timed, usually 24-hour urine collection, and simple tests for renal function performed. If the renal function tests are normal and the protein excretion is less than about 500 milligram per 24-hour, it is probably not necessary to subject the patient to further investigation, although follow-up should be arranged. أما إذا البروتين excretion is greater than this، يعني أكثر من 500 ملغ per 24 hour، أو renal function is impaired، further investigation is necessary and may include imaging techniques and biopsy. بالنسبة للأوفرفلو proteinuria، several conditions may give rise to abnormal amounts of low molecular mass proteins اللي هي أقل من about 70 kDa in plasma and in urine. إذن العديد من الحالات اللي ربما تؤدي إلى abnormal amounts of low molecular mass proteins اللي قلنا less than about 70 kDa في البلازما and في اليورين. هذه البروتينات are filtered بالجلوميرولس and may then be لا يصير بها absorption ولا catabolized completely by the renal tubular cells. إذن هذه البروتينات filtered at the glomerulus and may then be neither reabsorbed nor catabolized completely by the renal tubular cells. وهذا التable 4-6 be examples, principal examples. هنا نعطي examples من البروتينات ونعطي الموليكولار ماس مالتهن والكوز. مثلا الاميليز الكوز مالت الاكيوت بانكرياتايتس، البنز جونز بروتين مالتيبل مايلوما، الاتش بي الهيموغلوبين يصير في حالات الانترا فاسكولار هيموليسيس تحلل الدم داخل الأوعية الدموية، اللايزوزايم مايلومونوسيتيك لوكيميا كوز المايوغلوبين المايوغلوبين في الكوز مالت الكراش انجريز. بالنسبة للجلوميرولار proteinuria، table 4-7 classifies the glomerular proteinuria separately from tubular proteinuria, but many patients show features of both glomerular and tubular protein loss. إذن هذا table سنتكلم عليه اللي هو يتكلم عن glomerular and tubular proteinuria. فهنا مصنف الجلوميرولار proteinuria بشكل منفصل عن الtubular proteinuria، ولكن many patients show features of both the glomerular and tubular protein loss, where quantitative measurements of urine protein loss are required. Example, when monitoring treatment for the nephrotic syndrome, side room tests are insufficiently precise. هنا غلط مطبعي، هنا هاي كلمتين. Tests are insufficiently precise. Laboratory measurements are required. Some patients, typically with protein excretion rates of less than 1 gram per 24 hour, have benign or functional proteinuria. إذن بعض المرضى اللي عندهم typically with the proteinuria with the protein excretion rates of less than 1 gram per 24 hour have benign or functional proteinuria. This probably results from blood flow changes through the glomeruli. إذن هذا ربما ينتج من التغيرات في blood flow through the glomeruli and is found in association with exercise, fever, and congestive cardiac failure. Amongst these conditions, it is particularly important to recognize orthostatic proteinuria. وهذا التيبل اللي بيه classification هنا للبروتين glomerular proteinuria والtubular proteinuria. فبالنسبة للglomerular proteinuria may or may not be of pathological significance. Examples of causes: orthostatic proteinuria, effort proteinuria, febrile proteinuria. واكو of pathological significance مثلا في glomerulonephritis, all forms, pathological causes of altered hemodynamics, example renal artery stenosis. وبالنسبة للtubular proteinuria, for example of causes chronic nephritis and pyelonephritis, acute tubular necrosis, renal tubule defects, example renal tubular acidosis, heavy metal poisoning, renal transplantation. هذا بالنسبة للتيبل اللي هو على glomerular and tubular proteinuria. النفروتيك syndrome هذا الموضوع أيضا موجود في فصل البروتينات، ولكن هنا نتكلم فيما يخص البروتينوريا. In the nephrotic syndrome, large amounts of protein are lost in the urine, and hyperproteinemia and edema يصير due to the low albumin and secondary hyperaldosteronism develop. Usually, the protein losses in the urine are over 5 grams per 24 hours. More than this is filtered at the glomerulus, but most is catabolized in the tubules and is therefore lost from the circulation but does not appear in the urine. إذن اللي دا يتفلتر بالجلاميرولس هو البروتين، يعني اللي دا يتفلتر بالجلاميرولس هو أكثر more than this، أكثر من هذا ال 5 grams per 24 hour. ولكن most is catabolized in the tubules، ولهذا فإنه هو راح ينفقد من السيركوليشن but ما يظهر بالurine. The amount of proteinuria does not correlate well with the severity of renal disease. إذن كمية البروتينوريا does not correlate well with the شدة renal disease. Patients with nephrotic syndrome may also have a secondary hyperlipidemia. Causes of nephrotic syndrome include glomerulonephritis, systemic lupus erythematosus, and diabetic nephropathy. بالنسبة لموضوع glomerulonephritis, this is the most common group of causes of persistent proteinuria. The plasma proteins escape in varying amounts، وهذا يعتمد depending on their molecular mass, on the amount of glomerular damage, and on the capacity of renal tubule cells to reabsorb or metabolize the proteins that have passed the glomerulus. The degree of proteinuria does not provide an index of the severity of renal disease. However, it is convenient to distinguish mild or moderate proteinuria اللي بيها in which the loss of is not sufficient to cause protein depletion من severe proteinuria in which the protein loss exceeds the body capacity to replace losses by synthesis اللي هي عادة usually ما بين 5 إلى 10 جرام per 24 hour. Severe persistent proteinuria is one feature of the nephrotic syndrome, يعني احنا قلنا nephrotic syndrome هو واحد من الأسباب مالته هي glomerulonephritis. The severe persistent proteinuria is one feature of the nephrotic syndrome in which the urinary protein loss is sometimes more than 30 grams per 24 hours. Orthostatic proteinuria. This is usually a benign condition that affects children and young adults who exhibit proteinuria only after they have been standing up. إذن تصير البروتينوريا only after they have been standing up. For orthostatic or postural proteinuria to be diagnosed, protein is not detectable in an early morning urine specimen when tested by normal side room methods. اليورين contains أقل من 100 ملغ per liter. إذن حتى هذه الأورثوستاتيك أو البوستشوال proteinuria تشخص the protein is not detectable in the early morning urine specimen when tested by normal side room methods. اليورين contains أقل من 100 ملغ per liter. The patient is instructed to empty the bladder just before going to bed. إذن الpatient يعلم instructed to empty يعني يفرغ البلادر just before going to bed, and the test for protein is performed on a specimen of urine passed the following morning. والتحليل of protein ينجز في على عينات من اليورين passed the following morning في الصباح اليوم التالي, collected immediately after getting up. Orthostatic proteinuria is usually observed in only some of the urine specimens passed when up and about. And for these individuals, the prognosis is good. إذن الأورثوستاتيك proteinuria is usually تلاحظ in only بعض of the urine specimen passed when up and about. وفي هؤلاء الأشخاص the prognosis is good. It is less so يعني هذا prognosis it is less good يعني for those who in whom proteinuria is always detected. إذن في الأشخاص اللي يكون عندهم الأورثوستاتيك proteinuria عادة observed in only some of the urine specimens passed when up and about, يكون prognosis is good, ولكن it is less so في الأشخاص اللي البروتينوريا عندهم is always detected. أما بالنسبة لموضوع tubular proteinuria, this may be due to tubular or interstitial damage resulting from a variety of causes. The proteinuria is due to failure of the tubules to reabsorb some of the plasma proteins filtered by the normal glomerulus, or possibly due to abnormal secretion of protein into the urinary tract. إذن هذا النوع من البروتينوريا أسبابه تكون due to failure of the tubules to reabsorb some of the proteins اللي تفلترت by the normal glomerulus, أو احتمال بسبب abnormal secretion of protein into the urinary tract. The proteins excreted in tubular proteinuria mostly have a low molecular mass. For example, البيتا 2 microglobulin اللي هو 11.8 kDa and lysozyme 15 kDa. The loss of protein is usually mild, where rarely more than 2 gram per 24 hour. إذن فقدان البروتين عادة يكون mild، ونادرا ما يكون أكثر من 2 gram per 24 hour. Urinary beta-2 microglobulin excretion is normally very small، أقل من 0.4 mg per 24 hour. Its measurement has been used as a sensitive test for renal tubular damage. However, the test is of limited value for this purpose if there is evidence of impaired renal function, for example, increased plasma creatinine concentration. هنا القوس لازم يكون مثل هذا، خطأ مطبعي. فهذا اليورينري البيتا 2 microglobulin excretion normally very small، أقل من 0.4 mg per 24 hour. وهذا تم استخدام قياسه كsensitive test of renal tubular damage، ولكن هذا التست is of limited value for this purpose إذا كان هناك دليل على impaired renal function، على سبيل المثال زيادة البلازما كرياتينين concentration. وبهذا نكون قد كملنا موضوع البروتينوريا اللي تكلمنا به أيضا عن أسباب الأوفرفلو بروتينوريا، الجلوميرولو بروتينوريا، والنفروتيك سيندروم، Glomerulonephritis، Orthostatic Proteinuria، Tubular Proteinuria. والآن وصلنا إلى موضوع الرينال ستونز. بالنسبة للرينال ستونز فالفيزيكو chemical principles govern تحكم the formation of renal stone، تكون الرينال stones، and are relevant to the choice of a treatment. وأيضا لها علاقة في اختيار العلاج aimed at preventing progression or recurrence. Stones may cause renal damage. إذن الحصى ربما يسبب renal damage or often progressive. The solubility of a salt depends on the product of the activities of its constituent ions. Frequently, the solubility product in urine is exceeded without the formation of a stone, provided there is no seeding by particles present in urine, such as debris or bacteria, which promotes crystal formation. And then وجود هذه الدبريز or البكتيريا promotes a crystal formation. Formation of stones can also be prevented by inhibitory substances that are normally present in the urine, such as citrate. إذن تكوين الstones ممكن أنه prevented يمنع by inhibitory substances مثل إيش؟ that are normally present in urine، اللي هي موجودة بشكل طبيعي في اليورين، مثل إيش؟ مثل الستريت. شو يسوي هذا؟ which can chelate calcium و keeping it in solution. People living or working in hot conditions، إذن الأشخاص اللي يعيشون أو يعملون في hot conditions are liable، هاي كلمة واحدة، liable to become dehydrated and show a greater tendency، هاي أيضا كلمة واحدة، tendency ميول، and show a greater tendency to form renal stones as the urine become more concentrated. إذن الأشخاص اللي يعيشون أو يعملون في hot conditions يكونون liable to become dehydrated، وأيضا show a greater tendency to form renal stones لأنه الurine becomes more concentrated. There are also several metabolic factors that can cause stones to form in the renal tract. However, ولكن in many patients في الكثير من المرضى no cause can be found. لا يوجد سبب ممكن أنه يفسر explain why stones have formed. إذن في كثير من المرضى no cause can be found. لا يمكن إيجاد سبب ليفسر to explain why stones have formed. لماذا تكونت الstones. The main types of renal stones are listed in table 8 table 4.8 اللي هو هذا. في هذا الجدول أكو type of stone في هذا العمود، وهنا frequency in UK في المملكة المتحدة percent، وهنا metabolic cause or relevant factors. فمثلا النوع الأول calcium oxalate stones and mixed calcium oxalate and phosphate stones. هنا metabolic cause or relevant factors hypercalciuria, excessive absorption of dietary oxalate, وprimary hyperoxaluria. النوع الثاني triple phosphate stones. metabolic cause or relevant factors مالت urinary tract infection, the fall in hydrogen concentration. Urate stones metabolic cause or relevant factors مالت الgout, myeloproliferative disorders, high protein diet, والuric cause uric drugs. والcystine stones metabolic cause or relevant factors مالتها cystinuria، والxanthine stones بالxanthinuria. بالنسبة للhypercalciuria, stones in the upper renal tract occurs in 5 to 10% of adults in Western Europe and in the USA. These are mostly either pure calcium oxalate or a mixture of calcium oxalate and phosphate. Not every patient with renal stones, however, has hypercalciuria. إذن ليس كل مريض with renal stones على كل حال has hypercalciuria. Since بسبب أنه there is considerable overlap between the 24-hour urinary calcium excretion of healthy individuals on their normal diet up to 12 millimole per 24 hour, where the urinary calcium excretion of stone formers. Increased urinary calcium excretion may be associated with hypercalcemia. إذن زيادة urinary calcium excretion ربما يكون له علاقة بالhypercalcemia. For instance, على سبيل المثال, the primary hyperparathyroidism, vitamin D overdosage, and hypersensitivity to vitamin D, or with normal calcemia. إذن يا أما with hypercalcemia أو with normal calcemia. في حالة الnormal calcemia مثلا as in idiopathic hypercalciuria، هذه الحالة idiopathic hypercalciuria, prolonged immobilization, and renal tubular acidosis. إذن increased urinary calcium excretion ربما يكون له علاقة with hypercalcemia، وهنا نعطي الأمثلة عليه primary hyperparathyroidism, vitamin D overdosage, and hypersensitivity to vitamin D، أو له علاقة with normal calcemia، وبهيج حالات مثال عليها idiopathic hypercalciuria, prolonged immobilization, and renal tubular acidosis. In many patients with what was previously considered to be idiopathic hypercalciuria, the underlying disorder is an increase in intestinal calcium absorption. إذن في كثير من المرضى اللي what was previously considered to be idiopathic hypercalciuria ال underlying disorder هو زيادة بالintestinal calcium absorption. Up to 10% of renal calculi, depending on the series, have been attributed to primary hyperparathyroidism. It is important to investigate patients with recurrent renal calculi for primary hyperparathyroidism, as this condition can be cured. إذن من المهم to investigate المرضى اللي هم عندهم recurrent renal calculi for primary hyperthyroidism لأنه هذه الكونديشن can be cured. أما بالنسبة للأوكزالات السيستين and الإكزانثين excretion, the majority of urinary calculi contain oxalate, ولكن excessive excretion of oxalate is primarily responsible for the formation of stones in only فقط a small percentage of cases. Other occasional causes of stone formation include cystinuria and exanthinuria. إذن من ضمن occasional causes of stone formation. Primary hyperoxaluria is a rare condition in which there is increased excretion of oxalate and glyoxylate. The latter is due to deficiency of the enzyme responsible for converting glyoxylate to glycine. إذن هذا الأخير بسبب deficiency نقص في الإنزيم المسؤول responsible for converting تحويل الglyoxylate to glycine. Patients with disease of the terminal ileum، الإليوم هو جزء من الأمعاء الدقيقة، فالمرضى اللي عندهم disease of the terminal ileum may have an increased tendency to form oxalate stone، لأنه ربما يكون عندهم زيادة في الميول لتكوين الأوكزاليت stones. السبب due to the hyperoxaluria caused by increased absorption of dietary oxalate. الآن نتكلم عن موضوع chemical investigations on patients with renal stones. But stones should be analyzed for some or all of the constituents listed in table 4.7. إذن the stones should be analyzed لبعض أو كل المكونات اللي اتكلمنا عنها listed في table 4.7, as this can be helpful. The following test may also be helpful in reaching a diagnosis. وإذن الاختبارات التالية أيضا ربما تكون helpful للوصول إلى diagnosis. plasma calcium, albumin, phosphate, total CO2 and urate concentrations, and ALP, alkaline phosphatase activity. The full acid-base assessment is rarely needed. Urine dipstick testing, pH, البروتين، وأيضا measurement of 24-hour excretion of calcium, phosphate and urate. Occasionally, assessment of urinary excretion of oxalate, cysteine or xanthine may be required, or urinary acidification tests. A renal function test, plasma creatinine concentration and or plasma urea concentration. In addition to chemical tests، بالإضافة إلى الchemical test، microbiological examination of urine is usually performed, where radiological investigations of urinary tract will be required to localize the stone. إذن ال radiological investigation لل urinary tract will be required to localize لتحديد يعني مكان الستون.